Now it's my pleasure to introduce the moderator for the next session, Mira Morton. Mira is Director of Government Relations at the California Children's Hospital Association. She directs the association's legislative and non-finance regulatory activities and supports the government affairs executives for the association's 8 nonprofit freestanding children's hospital members. If you would like to know about the remarkable work Mira does and has done before joining the California Children's Hospital Association, please check out her bio under the speakers tab on the Hoover platform. And Mira, I'm going to turn this over to you now as we look forward to learning about what's new on the horizon for Medi-Cal and what changes may mean for children and youth with special health care needs. Thank you.
Great, thank you, Patty, and good morning, everyone. I am very excited to be moderating this important plenary session today, and the goal of this session is to give you an overview of the key Medi-Cal initiatives that the Department of Healthcare Services is currently working on, how they may impact children and youth with special healthcare needs, and also to highlight potential advocacy and feedback opportunities, and also to hear from a parent advocate and another association advocate like CCHA about what they're focused on as these efforts move forward so that they can help ensure that these initiatives address the unique needs of this special population. We will be moving through the session topically, hearing from the department and then our family and advocacy panelists. You can type your questions into the Q&A box as they occur to you, either in Zoom or in Whova, and I will pause between each topic to pose questions to the panelists as time allows. If we don't get through all the questions, we will follow up in Whova with responses at the conclusion of the event. And now, without further ado, I am pleased to introduce our panelists, beginning with our guests from the Department of Healthcare Services, Odeh Boylan and Dr. Palav Barbaria. Odeh is the Assistant Deputy Director for Integrated Systems and Healthcare Delivery Systems at the California Department of Healthcare Services. She provides strategic direction and implementation support for Medi-Cal's healthcare delivery systems, services, and programs, including CCS and the home and community-based services waiver programs. She has a Master in Public Health from Drexel University. Dr. Barbaria was appointed Chief Quality Officer and Deputy Director of Quality and Population Health Management of the California Department of Healthcare Services in March of this year. She's already done an enormous amount of work since then. She previously served as Chief Administrative Officer for Ambulatory Services at the Alameda Health System, where she was responsible for all outpatient clinical operations, quality of care, and strategy for primary care, specialty care, dental services, and integrated and specialty behavioral health, as well as an executive sponsor for value-based programs, including the Medi-Cal 1115 waiver. Palav received her bachelor's degree from Harvard and her medical degree and master's in health science from Yale University. And she completed her residency training here at the University of California, San Francisco. We also have Mike Odeh, who is the Senior Director of Health Policy at Children Now, where he focuses on health coverage, access, quality, financing, and care delivery. Previously, he worked at Health Access, a California healthcare consumer advocacy organization, and the Center for Children and Families at the Georgetown University Health Policy Institute. So a long history as a patient advocate. Mike holds a Master of Public Policy from Georgetown University. And last but certainly not least, representing the critical parent perspective, we have Allison Beyer. She has a long history of children's healthcare advocacy. She's a mom of 2 and a Family Voices of California Project Leadership graduate. Earlier this year, Ms. Beier was appointed Vice President of the FAIR Foundation, a nonprofit that promotes policies and activities to increase availability, access, and equity of solid organ transplantation. She is currently serving a 2-year term as a member of the Medi-Cal Children's Health Advisory Panel, or MCHEP. Before that, Alison completed a Department of Developmental Services grant-funded project on reducing disparities for regional center clients. She's also served as member of the UCLA Mattel Children's Hospital Parent Advisory Council since 2011, and as an advisory member of the California Nurse-Led Discharge Learning Collaborative, or CANDLE project, since 2019. So we're very grateful to have her here with us today. So before we jump into the discussion, I also want to give Allison a moment to share her son Evan's story, which is really what sparked her career as a parent advocate and as a patient advocate. So Allison, take it away.
Yes, before I start, Victoria, our interpreter, has her hand up. Victoria,
Just telling me to slow down. We missed it.
Okay. Hi, I'm Allison. Am I sharing my slide or are you sharing my slide? I'm sharing it, yes?
Yes.
Good thing I pulled it up. Don't mind my shaky hand here. It's generally it's easier to see you, and I don't see any of you, so it makes it a little more nerve-wracking. So hi, I'm Allison Beyer. I am from Torrance, California. I am a mom of two. These are my adorable children, Evan, who is 12, and Tegan is 6. Evan was the start of, well, me having any sort of self-confidence, because I was the type of person who would call for a pizza and be nervous because I thought someone was making fun of me. So once Evan came on the scene, he showed me that there was a different version of me that was necessary and needed for him to thrive and survive. And so he sort of became my hero. Evan is a 2-time kidney transplant recipient, and I am a living donor. So I had the great, unique and distinct privilege of being able to provide life for my child 2 times. And so that was probably him being the most beautiful blessing, her being the most beautiful blessing, and then that being just something that kind of blew my mind away. Evan has had, we lost count, but over 80 surgeries. He was on hemodialysis for the beginning of his life for the first 2.5 years. Even though he has a kidney, we don't get to just have a kidney and be off and running. We go to the hospital at minimum 2 times a month for infusions, and then we're in and out of the hospital semi-regularly at this point. But from the Medi-Cal perspective, Evan is a Medi-Cal recipient. He falls into this niche group of he could qualify for a waiver if we chose a nurse. Evan gets 50 hours of nursing care a week he would qualify for. And when he was a baby, I chose to be his care provider instead. And so I get to be his provider for the in-home supportive services program, which is something that Medi-Cal pays for. And because of that, I've been able to be with him for all of that time and have really unique experiences where I've actually saved his life on more than one occasion because of the fact that I'm the main healthcare provider and I'm the one that can see all of the nuanced things. So the program in-home supportive services is pretty tremendous in the way that it supports me to be able to stay at home with him. Evan also uses the Medi-Cal system for durable medical equipment. So we get supplies from 2 different companies. That's every month. He gets prescriptions. He's a special guy who dentists, like normal pediatric dentists, don't want to touch him. They get a little scared. So we use a dental Medi-Cal provider at UCLA at the hospital for his dental services. We get prescriptions. We've done trauma clinics. UCLA has a special trauma clinic for kids with medical trauma. So we've done that with Medi-Cal. We've also in the hospital and doing the doctor appointments. So we're heavy. The hospital, we used to call him a frequent flyer. We thought that was funny. And we found out that he's a high utilizer. So we're a high utilizer of the hospital system. We're a high utilizer of Medi-Cal. And the thing that got me to the Medi-Cal Children's Health Advisory Panel was that Evan doesn't qualify for a waiver because I am his parent provider. Again, he would qualify if he had the nurse through the home and community-based waiver, or he would qualify if he had an intellectual disability through the regional center. He does not qualify for either because I chose to be his provider. And so we reside in staying under the income limit. And every year, if I have a misstep or something, like it could be taken away. And so that was something that happened to us is I chose to separate from his father. And before the official divorce, we went into another apartment and Medi-Cal was taken away from us because they were lumping it in, long story. But anyway, so once I fought for that, I wanted to make sure that I ensured that we weren't people like us, that when the Medi-Cal, like anytime Department of Healthcare Services mails something to us, there's like this impending fear. It's always something that gives us life and yet it could be taken away in an instant. We represent that population. And I wanted to make sure that that population had a seat somewhere where we had a voice. And that's where I found the Medi-Cal Children's Health Advisory Panel. And I applied for that, and I'm completing a 2-year term, and I'll be sworn in for an additional 3-year term in December. And so I am here to tell you, if you are like us, I am your voice, and please use me so I can represent you on the panel. Thank you.
Thank you, Allison, for sharing Evan's story and for your fierce advocacy on his behalf and on behalf of all children and youth with special healthcare needs in California. I know you're getting lots of shouts out in the chat, so a lot of people who can identify with what you've gone through and what you're doing for them. It's now time to turn to our first set of topics: population health management, quality, and health equity, which, as you'll learn, are very interrelated. And I'd like to turn it over to Palav and Odeh to talk about what the department is working on in these areas.
Thank you so much, Mira. Hi, everyone. I'm Palav, Babaria. Really just want to start off by saying how honored and privileged we are to be here today with all of you. You know, I think at the end of the day, what we're trying to do at Medi-Cal is to make the system work better for families and individuals like each and every one of you. So just really grateful for the opportunity and really looking forward to both the dialogue and any and all feedback, questions, thoughts, anything that you all have for us. So I don't want to get into the slides in too much detail, but we're really just going to provide a high-level overview of where the Medi-Cal program is headed. There are lots of changes with Cal-AIM, with the creation of my role, and we hope that they will all be changes for the better. We can go to the next slide. You can go to the next slide too. Perfect. So we are working on updating our comprehensive quality strategy for all of Medi-Cal right now. I'm in charge of writing it, and it will be coming out for public comment later this month. And the goal of the quality strategy and the health equity roadmap is to really set out ambitious goals for us as a program and to say, you know, for each and every one of our members, where do we want to get to in terms of healthcare quality, experience, and health equity. And so just to cover the goals, as we implement Cal-AIM, we're really going to be shifting to a system of care called population health management. And the goal of that is, you know, as all of you know, healthcare can be really reactive and episodic. You know, when you show up to the ED, you get care. When you're hospitalized, you get care. And unless you're sort of in a specialized program, we aren't always thinking about the entire community and the entire population and what is happening with people when they're not in the hospital or the ED in their doctor's office. What do we need to do in between visits to keep people safe and healthy and living their best lives? And so population health management is a framework so that we can really take care of people, really focused on prevention, but as well as making sure we have all the wraparound services, coordination between different settings of care and different types of providers, that we really take care of the whole person. So the 4 goals that you see in the blue boxes are really designed to help us get to population health. First and foremost is really, you know, a commitment and a principle of having members be engaged as owners of their own care. So that means all of you, you know, in both ways of engagement, like Alison just talked about, you know, informing our policy, really helping us design better programs, making sure that our programs are really working for families and for individuals, but also really prioritizing member experience. I'm sure all of you have filled out at least one of those, you know, annoying multi-question surveys that come, and we really want to take that feedback and see what are our opportunities to make the experience better so that it doesn't have to be so hard navigating the healthcare system. The second goal is the bottom of what we call our population health pyramid, or the foundation. And that is really focusing on prevention so that wherever we can, we are keeping families and communities healthy. The third goal is really, you know, if people do develop conditions, how can we recognize issues early on and really intervene before things get too late? And, you know, Alison again just described how powerful it is that she's a caregiver and was able to really recognize subtle changes in her son's condition before, you know, anyone else in the healthcare system did. So how do we provide early interventions when there are new diseases, when there are new issues that arise, as well as really effective chronic disease management before conditions become too serious? And then obviously, we know, so the fourth goal is that there are lots of people living with really complex medical conditions and
Oh, Dr. Barbaria, are you back? No, kind of.
I'm back. Where did I cut out?
It's like maybe half a sentence ago.
So goal 4 is really, recognizing that there are populations who have really complex needs, and those needs need to be met in a coordinated way inside and outside of the healthcare system. And then we really have 3 guiding principles that all of you will start seeing in everything that we do. First and foremost, eliminating health disparities, really leveraging community-based partnerships and an anti-racism framework, using data to drive improvements for the whole person. So this means not just medical data, but social data as well, connecting across social services agencies and departments, and then really being transparent and accountable to the public, and involving members in everything that we do. You can go to the next slide. So as a part of this, I do want to just plant the seed, and when we get to sort of discussion time, would love to hear people's thoughts. The department is going to be launching something called the Population Health Management Service, and it's going to be basically like an online portal where it will combine all the different data that we have and assessments and help our managed care plans and providers better take care of patients. But we also envision this portal having individual patient logins too, so that if you're a Medi-Cal beneficiary, you can log in and access your own information and your own data. And I would love to hear from all of you, having this sort of statewide tool, which will break down some of those silos between counties, between plans, between providers, and between, dental services, behavioral health services, and physical health services. Would love to hear, what would be on your wish list for this portal? What are the pieces of information from Medi-Cal that are missing for you that you would like to have access to? And go to the next slide. So as I'd mentioned, putting members at the center of our work is critical if we are going to really achieve the full potential of our program and improve quality and reduce disparities. And so we know, we can sit in a room as DHCS and make decisions, and those decisions may or may not actually solve the problems we're all trying to solve together. And so I just invite each and every one of you, as Allison mentioned, to, if you have the time and the bandwidth, to become engaged or leverage the representatives that you have so that you can provide feedback on all of our policy and program design decisions. And especially as we start to look at healthcare disparities, we know there are disparities by race and ethnicity. There are disparities by disability status. There are disparities by geography, by age, and really understanding what the needs are of those communities that maybe aren't getting the health outcomes they need or deserve will help us make better program choices. And then there's a number of things we are doing through CalAIM to really improve member experience. So, within CalAIM, there's a lot of jargon and stuff in there, but one of the principles is really standardizing how managed care enrollment works, as well as benefits across the state, so that there isn't as much variation from county to county, so that if you move, you don't have to sort of, have your entire healthcare system upended. We also are going to be integrating some of the behavioral health side between drug Medi-Cal and the mental health side, so that people who need treatment in both of those settings can also have a more seamless experience. Doesn't apply as much for this group right now, but for seniors and duals, we're going to be doing a lot of work so that people don't have to navigate so many systems. Through the home and community-based spending plan, there's going to be a lot of enhanced access and new programs, which are going to be really valuable. As I mentioned, we're really doubling down on member experience. So improving the frequency of how often we're asking members about their experience, doing more with that data, and using it to hold all of, our plans accountable to improving the member experience. So when you get those surveys, please fill them out. And then we're also going to be incorporating member experience into how we pay our managed care plans, so that there's even more dollars tied to making that experience more effective. You can go to the next slide. And I know I'm probably talking too much. This is just to say we really want to take the long view of health and wellness in California. What changes do we need to make to our system now so that 10, 20, 30 years from now, our populations are really have lower rates of chronic disease, lower rates of severe illness, in as much as we can prevent it. Not all conditions can be prevented, but we're going to be launching new initiatives around children's preventive care, behavioral health integration, and the maternity outcomes and birth equity in the coming year. You can go to the next slide. And so as part of that, all of these quality goals, we are going to be launching our Bold Goals campaign. I recognize not all of these affect your children, but I do think many of them overlap and will lead to substantial changes that improve clinical outcomes. So first and foremost, we want to make sure that each and every one of our managed care plans is meeting our basic minimum targets for all children's preventive care measures. We also want to close the racial and ethnic disparities that we see in well child visits and immunizations by 50%. We also want to close the maternity care disparities that we see for Black and Native American persons by 50%. We want to improve maternal and adolescent depression screening by 50% so that we can detect depression early and intervene early. And we also want to improve the linkage when people do have behavioral health conditions, either mental health or substance use, to the follow-up care that they need by 50%. You can go to the next slide. I talked a lot about health equity. This slide is really a placeholder. The department is going to be weaving health equity into everything that it does, really first and foremost by improving how we collect data so that we can identify the disparities. If we can't even measure it, we sometimes don't know that it exists. We really want to make sure that our workforce at the state level, at the plan level, at the provider level, at the community level really reflects the diversity of our Medi-Cal members, and that the entire workforce, regardless of their diversity, can provide culturally responsive and linguistically appropriate care 100% of the time in every setting. And there's a long way we have to go for that. And then we know there are disparities in different areas. And what are the programs and partnerships that we need to create to start eliminating those disparities? We can go to the next slide. And so what's going to happen is in our quality strategy, we're really just sketching out a framework for health equity that I call the skeleton roadmap. It sort of outlines what we're doing today, but we're going to be launching a pretty extensive effort in 2022 to invite the community and partners. And I'm hoping many of you at this meeting will join that effort to really say, what are the disparities that we see and what is the future that we envision and how are we going to get there so that we can together really come up with a 3 to 5 year roadmap for addressing some of the issues that are leading to health inequity. We can go to the next slide. Autumn, I think I'm going to pass this over to you now.
Oh, I'd like to pause.
Oh, sorry.
So maybe we can put the slides away for a moment, whoever's in charge of them, I don't know. So thank you very much, Palav, for that overview of the department's really important work in this area. I know you've been working very hard on this in your time here. I'd like to turn it over to Allison for a moment to get your thoughts on what do you think this means for the families here and what are you keeping an eye on as these initiatives move forward?
So this is a really big thing for me. And sitting on the panel, I've heard them talk about it for 2 of the meetings. A year ago or so, when Lightburn had come to the helm, and he's since now passed. He was a transition, but he was the director. He was very, very serious about like, this ends now. The fact that, certain people, there's certain cities where kids have asthma, but not anywhere else, or with African-American women, with the mortality rates in maternity, like there's certain things that are very clear and haven't really been addressed. And he came in and said, we're going to end this now. We're really going to be serious about it. And sometimes that happens and people say it and everyone's like, well, but like what happened was that I saw really competent and capable people step in at the helm. I saw people like Palav, who's just so impressive. take over things. There's so many women as part of healthcare services. I'm so blown away. People of many colors and facets, and like, this is really, they're really doing it. Like, this is it. Like, from a sincere standpoint, this is the first time that I've seen anything where they're really dedicated to having all like voices at the table, everything covered. And when Palav is saying we're sending out surveys, I'm encouraging parents, I'm encouraging families, fill them out, because this is our time. This is it. We get a say in all of it right now. And they're deadly serious about this. I'm constantly blown away by every update they've given about it. Some of the things that are really beautiful, like in our situation, is in the CalAIM, and sometimes I get things crossed over because Department of Healthcare Services has all kinds of like jargon that I don't know, but in CalAIM, one of the things I believe is the early screening for trauma. Is that accurate? That's a huge one to me. They're really prioritizing mental health. I'm sure they talked about it either yesterday or later today, really having that be commonplace, having it be talked about. For my son, that's been crucial in his development. He was a boy that they would say, oh, he'll go through all this, and at age 3, he'll be transplanted and it'll be fine. He won't remember. And it's true, he doesn't remember. But a month ago in the hospital, when he had 2 nurses go to put the 3rd needle into his port because they couldn't get it right the first 2 times, the one nurse remembered him as a baby, and she put her hands on his feet just to kind of pat him. And he stopped her and he said, I don't know why, but I don't want you to touch my feet, because when you touched my feet, I felt like you were going to pin me down and hold me down. And I said, thank you for telling me. That's actually true. We did hold you down and pin you down when you were screaming and saying, please no, please no. Like, that's something that did happen to you. You don't remember it. And so what I got really clear on was, if it wasn't for the trauma work that we had done, he wouldn't have had the wherewithal to explain what was going on in his body. And if it wasn't for that like awareness on my end either, like he would have had some sort of reaction and never known where it came from and thought there was something wrong with him, right? So every person that said between 0 and 3, he wouldn't remember, he doesn't. But luckily I get to be there and fill in the blanks for him. And that's what that kind of early detection in trauma does. It helps them process. And then that can be something that's not frozen in time for him anymore. Like, that can just get filed away somewhere in his brain and be a memory, as opposed to this place in time where he was brought back in an instant because somebody just lovingly pet his foot. So I think that that's like a really huge one. I could go on forever, but the continuity of care, being able to see how everything's done online, like UCLA has a system where, like, as soon as Evan's labs are done, I'm able to see them. I can have like really great dialogue with the doctors before they even show up, because I've seen things in the labs. I can schedule, appointments there. I can talk to the doctor. I can send them a message. That kind of access is huge for Medi-Cal to be doing that. And especially another thing that came up, and you have to, Palav, you got to tell me if I'm doing this one wrong, but another thing that came up was, if you're in San Diego and your specialist isn't down there and you need someone in San Francisco, then you can go up to San Francisco, as long as they're in Medi-Cal, even if you're in a managed plan, and see that person. Is that accurate? Because that was a big one to me too, was that you're not like stuck somewhere where you don't have the support that you actually need. Did I get that one right before we move on? Palav, was that right?
I'm going to look at that at Adam for an answer. I do think that's right in certain circumstances, but I don't know if it's like a blanket statement for any and all situations. So Adam, if you have more details, we'll beg for your expertise.
Okay. So
yeah,
Adam,
that might be one that we want to go back and clarify with the team on,
okay.
But definitely appreciate and have heard in the past kind of concerns around that. So, I think that we can clarify the kind of ongoing future policy for that at following this session. So apologies that we don't have an answer.
It's okay. At the end of the day, what it is Department of Healthcare Services right now is so dedicated to make sure that we have everything we need. And they really get that it's not just what's on paper. It's not just the lab work or the data or even like what they look like in clinics. It's really everything. And they build it out everywhere. It's equity, it's communication, it's seamless transitions. It's literally like, if they're thinking of it, like, or if it's to be thought of, they've thought of it. And if they haven't, that's where you come in, because this is it. This is like the space that we can really transform healthcare in California and healthcare across the nation because they're looking at us. So if we put this together, and I'm talking to all the parents, we can do this in collaboration with them. We get to be at the helm. We get to change and transition and transform healthcare as we know it in the United States right now by working with Department of Healthcare Services to give them everything they need, because this is it. This is our time. So I'll be done.
No, I thank you, Allison, and really appreciate your enthusiasm on all of these issues. I'd like to turn it over to Mike Odeh now. So Mike, what is your perspective from the Sacramento, you're not Sacramento based, but the Sacramento advocate perspective on population health and the quality work?
Yeah, thanks, Mira. And thanks for your presentation, Palav. I think we're really excited about the transformation that this can do for the Medi-Cal program. I think laying out the big, bold goals are really important because Medi-Cal really hasn't had those kind of big, bold goals. I want to echo Allison's comment about folks getting involved and making your voice heard. I think it's really important, and the department does want to hear from you. So it's important that members and affected consumers are weighing in, so that as things like population health management is designed, that it really serves the needs that it's meant to. I know it will take some time to build it out, and I know it'll take some time to get socialized, but I think it could be transformative. I do worry a little bit that we could run the risk of kind of relying on algorithms that have some biases baked into them, and relying on research that's maybe been done on adults, but isn't really done on kids. And so I think just making sure that there's a strong kid and youth and family voice in there. We're really pleased to be supporting Palav and her team in a commitment to bringing stakeholder group together in California and get some technical support from the feds to really focus on infant well child visits, which have very low rates. And we know that there are disparities. And so really having that intentional focus on how to improve them is also a new direction for DHCS. So we're really excited about that and what that can bring. And then I just want to touch on the payment issue. Palav said that payment is going to be tied to member experience. And I think that's huge because we're really not going to get the outcomes and the improvements we want if we keep paying in the same way, where we're paying for services that may not be delivered or may be delivered poorly. So I think changing that dynamic is also hugely important. So I think we're really at a pinnacle of some of these transformative changes, and I'm really excited to be a part of it.
Thank you, Mike, and really great points. And also just, I think for all the folks out in the audience, I think this is why, we have these really big initiatives taking place that span the entire breadth of healthcare, adults and children. And this is why your advocacy is so important, is helping make sure that really critical issues like the ones Mike raised stay on the radar, and that kids and children and youth with special healthcare needs really do get some attention as we work on these big, broad, important issues. So thank you, Mike, for making those points. We do have a few minutes for questions on this topic, and I have quite a few questions and comments in the queue. I was wondering if I could turn first to Victoria. It looks like we have some comments or questions. I'm not quite sure, from Caddy Perea. Victoria, are you able to interpret the questions for us?
I'm not sure that Victoria will be able to. I will work on some written translations.
Okay, and Caddy, we will get to your questions offline. All right, we have a question in the chat, Dr. Barbaria. So first, just a comment, wow, that was very interesting. That would make portability within California so much more consistent. I learned from a family in a different state having lost their electronic health record, which included data on their child's heart transplant surgery, when the medical institution changed platforms. Poof, gone. Will you be sharing the backup strategies? I'm confident that you'll be stitching tight the PHI privacy piece.
I think all amazing points. And, this is a conversation that's happening not just in California. The Cal Health and Human Services Agency has a working group, an advisory group to look at data exchange across the state, but it's a nationwide, topic as well, that we all know as we're in the 21st, century, we really need to focus on data and people having access to data. And for healthcare, sometimes not having that data, is critical to the outcomes of patients who are seeking care. I am by no means the sort of legal or data expert, but we have a ton of those at DHCS who are absolutely going to be involved in this process to make sure that we still protect, privacy of individual folks, that they have their rights to sort of, decide how their data is shared among different healthcare entities, that we comply with all the state and federal regulations in this space. But assuming we work all of that out, the goal is really to help democratize this data and give the people who need access to it access to better care for themselves and their patients.
Excellent, thank you. We have a comment from Brenna, and I just want to raise it, that she had so many suggestions for integration. I want to raise it. I know Allie reached out to her. If anybody out there has ideas and you want to know how to share them, please do use Family Voices to figure out where is the best place to share your ideas. We want to make sure that we help inform this process, and your ideas are welcome, as Palav and Odeh have both made clear. But Family Voices would be a great kind of go-between as you figure out how to navigate and where to provide your feedback. Ben Mizell had a comment, through CCS, it can be possible to do what Allison Beyer spoke about, where a child with CCS who needs care at another facility in a faraway California county can get care approved if not available in their local county, which is true. Some thank yous, and then let's see. Counties look forward to partnering with you, so that's wonderful. So it looks like those, oh, no, there's more questions over here. Many windows. So we have I think a comment here. This portal should also include so you had asked Palav about the portal. Should it also include what service providers are available, such as nursing care for those who have the nursing services waiver? As it stands, we cannot find a nurse for a child with complex needs, and the agency we work with that holds the nursing contract through the waiver has not provided us with a nurse for years and has just pulled the nurse from our case without a replacement. Yeah, I think access to nursing care is a tough one. And then, will the future population health management portal also include DHCS and CCS data so families can see service authorizations and communicate securely with their CCS nurse case managers? Right now, there is no patient portal for CCS. I think that may end up staying local, but a good.
No, but we love the suggestions, right?
Yeah.
If we don't raise it, we want to get the wish list, and then we will deal with what is or is not technologically feasible. So if you have wishes, just put them in the chat, or you can reach out to us afterwards too, because we want to collect all of those.
Wonderful. All right. I think I got all the questions and right on time to move on to our next topic. So Autumn, I think whoever was sharing the slides, I think that was Autumn. Our next set of topics is supporting members with complex needs, enhanced care management, and community supports. And these are a part of the larger CalAIM initiative, which I think you all heard a little bit about yesterday. So I will turn it back over to the department.
Okay, great. Thank you so much. You did hear about CalAIM a little bit yesterday from our Deputy Director of Healthcare Delivery Systems, Susan Phillip, and others who presented yesterday, as well as Paula's sharing kind of some of the population health management aspects of CalAIM and really what we're focusing on there. But it really is a multi-year initiative to improve the quality and health outcomes of California residents by implementing broad delivery system program and payment reform. And we have lofty ambitions. Two of the initiatives that are really critical and kind of foundational for the CalAIM initiative are the implementation of new benefits in the Medi-Cal managed care space, which include enhanced care management and our community support initiatives. I'm going to start by talking a little bit about the enhanced care management piece. There's a lot of information about enhanced care management also available on our website. So if you would like a more broad overview or a more in-depth overview, I should say, there's a lot of detailed guidance on our website, including a specific policy guides for each of these initiatives. But enhanced care management is really a whole person interdisciplinary approach to care management that addresses kind of all of the clinical and non-clinical needs of the Medi-Cal managed care enrollees who are eligible for that enhanced care management benefit. It's really meant to be a high touch system of coordination of services that really touches, like I said, the medical, social services, housing, and really focuses on kind of the whole person needs of the individual. The program builds on the current health home programs and whole person care pilots that have been in place, and will replace both of those models in what was part of our previous waiver package, and will scale up interventions to form a statewide care management program. It is a Medi-Cal managed care benefit and not available in our fee-for-service delivery system, and we'll start phasing in the enhanced care management benefit starting in January, so just right around the corner for specific populations of focus, which I'm going to talk about now. There are 7 mandatory target populations in the enhanced care management benefit. It includes individuals and families experiencing homelessness, adult high utilizers, and adults with serious mental illness and substance use disorder. For those populations of focus, the enhanced care management benefit will go live in January of 2022 for those counties where there were whole person care pilots and health home pilots. In July of 2022, those target populations of focus will go live in all other counties. We also are including incarcerated individuals who are transitioning into the community, individuals who are at risk for institutionalization and eligible for long-term care, and nursing facility residents who are transitioning to the community as populations of focus beginning in January of 2023. For children and youth, we will include populations of focus that include high utilizers, children and youth with serious emotional disturbance, or children who've been identified as high clinical risk for psychosis or experiencing first episode of psychosis, children who are enrolled in the California Children's Services Program, including the whole child model, who have additional needs beyond the CCS qualifying condition, and children who have been involved with or have a history of involvement in the child welfare system. And for those children, enhanced care management will be available in July of 2023. There's been a lot of work that we have already done to kind of define these populations of focus and what the benefit will look like in each of these areas. However, for the children and youth population, there's a lot more kind of developmental and foundational work that we will need to continue to do to really flesh out the benefit and understand how the benefit will work best for children and youth. So we plan to conduct additional stakeholder opportunities and engage with you and stakeholders across the state to really shape and focus what that benefit will look like for children and youth when we go live. Particularly, there will be an emphasis on getting stakeholder input around the design of ECM for children and youth who are enrolled in California Children's Services, including the whole child model. But we do want to note, and Susan may have mentioned yesterday, that the enhanced care management benefit will not replace CCS. So it's really meant to be a complementary service that will be an additional benefit for children who are receiving CCS services, either through the whole child model or through a non-whole child model county. Let's see. We also are launching a slew of community supports that we formally refer to as in lieu of services. So you may be familiar with this package of services that will be available. It's a series of 14 pre-approved community supports that have been determined by the department to be medically appropriate and cost-effective alternatives to services that would otherwise be available in the state plan. The service package for community supports are optional for the managed care plans to implement, and each plan has submitted a plan to the department indicating which set of community services they plan to launch starting in January and going forward. And those are all available on our website. the managed care plans really do need to balance kind of the medical appropriateness and cost effectiveness of the community support benefits. But those community supports are meant to provide options to people to prevent institutionalization and hospitalization. The list of 14 community supports is shown on the screen here. It's a really a package that really kind of spans the social service needs, home and community-based services, as well as the medical needs of our participants, and kind of really hearkening back to that population health focus that Paul was talking about earlier, but in a service capacity. Let's see. There's, like I mentioned at the beginning of the presentation, there's a lot of resources that are available on our website that describes each of those community supports, as well as the enhanced care management benefits. We really just wanted to give a high-level overview and make sure that we had time for your questions today. So I think with that, I'll turn it back over to Mira, and we'll hear from Allison and Mike.
Wonderful, thanks, Autumn. So Allison, yeah, tell us your thoughts. I'm sure you've talked about this a bit in MCHAP as well on enhanced care management.
So it's funny because I'm so high on Dr. Barbaria and everything they're doing, and then I'm going to come in. So Autumn, this isn't personal to you. The ECM, to have that enhanced care management and to have that coordination is such like a pie in the sky thing to me. And I know CCS, Evan never qualified for CCS in that way. So I have it that there is a working model that you have data on that you can use I know you're not replicating it, but there is stuff there. For me, just based on like my on the ground experience, like I feel like I've lived at such a high level of, I don't want to say intensity, but like I've really kept a watchful eye to make sure that there's been no missteps, because any misstep could lead to something awful for Evan, and the level of which I've had to intervene and collaborate and go back and forth and spend hours on the phone, like that hasn't changed for me. That's just my high level of like, maybe that's, how the parent provider endures like that chronic trauma as well. So I sit in that space. So when you say all of these things, I want all of these things, and I'm still waiting to see. I trust the Department of Healthcare Services because I've seen what everybody's been doing, and I trust that you are moving forward, and I'm waiting to see more before I start to like relax, because if I relax, something could happen, right? So I sit there and I go back to Mike Odeh, what he says, like, make sure we're using data for kids. A lot of the times children are kind of an afterthought. I get that they're not in this plan. I see that you've intentionally left them like on the back end of it so that you can see all the data and really have things work for them. But I want to make sure I caution, like really get that we're distinctly different than everyone else. We're not the same population. In-home supportive services was kind of that program where we just got tagged on and it never really adjusted for us. It just seems like whenever there's discussions, there's the senior population, and then there's like the afterthought, which is our children. So that's kind of where I stand. And I feel really bad, like from a moral perspective, to deliver that to you, Autumn. But that's where I'm at. It's just, I'm kind of a wait and see. I really do believe that like you're going to move it forward and have, you work in close tandem with children now. So I just want to see it. And then shout out to Nancy Netherland, because I saw she had a comment. She's also on MCHAP. So I wanted to give her a shout out before I was done.
Awesome. Thank you, Allison. Mike, want to give us your advocacy perspective on this? I know you spent a lot of time thinking about ECM. We have a lot of conversations.
I spent a lot of time talking about enhanced care management and what it means or may not mean. I think I'm also, like Allison, really curious to see how it shapes up. I think the good news is that Autumn did say that they will be engaging stakeholders. So I think the runway of about 1.5 years before the benefit goes live for most kids, I think is really critical and important. I think there's a lot to learn from existing pilots and programs, as well as how enhanced care management launches for adults. But like Allison said, kids are a little bit different, and we need to think about this benefit differently if it's really going to serve those kids. So we need to be talking about families. So the kids, their parents, their caregivers, their siblings. We need to talk about different settings. So, you know, if it's really about coordinating all of the care that kids need, then we need to be talking about schools and early learning settings, things that aren't really relevant when you're rolling out a program for high utilizing adults, for example. I think the interaction between whole child model and the vision of enhanced care management is still a little fuzzy to me. But I think with the engagement and the conversations, we can figure out what, how to build on what exists and not duplicate services, which I know is one of the goals. I think all of that coupled with the community supports can be really powerful in terms of improving health. So I'm really excited about what respite care and as remediation can mean for the health and wellness of kids and their families. I will caution though that one of my main concerns is that a lot of this depends on the way health plans decide to roll out these programs. And so we could have a bit of a patchwork where some plans in some counties or some parts of counties may have community supports that other parts don't have, or a kid may be eligible for enhanced care management in one plan, but not necessarily in the other based on kind of the specifics of how that plan is defining eligibility. So I do worry a little bit that there could be some of those issues, but I will be optimistic of where we're headed. And I think, again, stakeholder engagement is really important. And so I really hope that families have a lot of opportunities to be sharing ideas and information, and then vetting some of those decisions before actual policy gets decided.
Yeah, I think a lot of work still to come here, but exciting to have another layer of case management and coordination for these kids, especially with the most complex medical conditions. So we look forward to working on that. We have a number of questions for, I think, especially for Odeh and Palav, just to kind of clarify how this interacts with things. So the first one, what is the thinking for enhanced care management services for children with fee-for-service? It seems that this benefit stream has a high proportion of children living within medical complexities. So how will it work, managed care versus fee-for-service CCS?
Yeah, so that's a good question. And it is a managed care benefit. So it's only going to be available in the managed care space. However, as Paul was talking earlier, sharing earlier in the conversation, with some of the benefit standardization and kind of shifting of populations into managed care that are happening as part of the larger CalAIM effort, most of the children and youth statewide will be enrolled in managed care. A good proportion of them are enrolled in managed care today. But once the transition of like the duals population and other transitions happen into the mandatory managed care requirements in July of 2023, then almost all of the kids will be in managed care. Almost all Medi-Cal children will be in managed care, and so it really is meant to be a benefit that is available statewide, but it is not going to be available in the fee-for-service space. And again, most kids will be in managed care.
Can I ask a clarifying question on that, Odeh?
Yeah.
So if you have a kid who's in CCS, but then their general health care is in a managed care, will that managed care plan potentially identify them for ECM, or they're just not eligible because they're in CCS fee-for-service?
No, if they're enrolled in a managed care plan for their healthcare services, they would be eligible. They're a managed care member and enrollee, and then eligible for the benefits that are available under the managed care plans and covered by the plans. As we've discussed earlier, and as both Allison and Mike mentioned, there's going to be a lot of planning still to come around the design of the enhanced care management benefit and what that would look like. And so, we really do, just to kind of reassure folks, plan to, with our partners at Manat Health, engage stakeholders, including family members and all of you, around what that would look like, how we operationalize that for children who are receiving services through the CCS system, where it's not in a whole child model county, but the plan is responsible for delivering kind of the array of healthcare services available to the child. So, you know, there's still a lot of work to come, but any child who is enrolled in a Medi-Cal managed care plan and meets the criteria for enhanced care management would be eligible.
Got it. That makes a lot of sense. We have another question, wondering if this has an impact on the GHPP program, such a narrow program, but useful for those who used to have CCS.
Sure, yes, we are definitely looking at the interaction of enhanced care management with GHPP and expect that there will be also some kind of overlap in terms of the populations that are served. That's actually expressly laid out in terms of our ECM policy guidance. And I can look that up and provide kind of what the policy guidance says related to that, because I'm not recalling it off the top of my head, but it is certainly part of the conversation and the design of ECM to kind of think about the overlap of existing programs and how ECM works with those programs.
Yeah.
I do know that, like, for some of the waiver programs, a participant can't receive like home and community-based service home and community-based alternatives waiver and ECM at the same time, because there is so much overlap in terms of the expectations for case management that happens in those programs. And that's true in a lot of the 1915C programs, but there is in the ECM policy guide, there is kind of an outline of how the program interacts with the various kind of other standalone programs that we have at the department.
Yeah. And I think Lisa, who asked the question, I would just say there's no intention for CCS or GHPP to go away. This would be a benefit on top of those services for patients, you know, for enrollees who have been identified by the managed care plan as needing additional support on top of what they're already getting through CCS or GHPP. So
absolutely.
Yeah,
the programs, these are not replacements. This is just an additional benefit that will be available in the managed care environment. But the GHPP and CCS programs, the waiver programs, will all still continue to function.
We have a question. Can you speak more about how the eligibility requirements for ECM will be determined? I know a lot of that probably we're going to figure it out down the road, but you may have some thoughts on that now.
Yeah, so I mean, we've done some work on that, like I mentioned, and there is the ECM policy guide that's available on our website that kind of outlines some of those pieces. But in terms of children and youth, we really do plan to engage stakeholders further around kind of the design of enhanced care management for children and youth. And so some thought obviously has already been done and kind of put into the guidance, but really wanted to kind of leave it open. A couple of reasons for that. One, because of the mandatory Medi-Cal enrollment that I just mentioned, and kind of the transition of populations from fee-for-service into managed care happening in July of 2023, we thought that would be, good timing to kind of launch the enhanced care management benefit for children and youth, since at that point, most of the children statewide would be enrolled in managed care. We're also wanting to kind of learn from the implementation for the other populations and addressing some of the issues that that Mike mentioned earlier around kind of the way that plans define eligibility and making sure that we're monitoring that appropriately so that there is some consistency statewide in terms of how that's done to the extent possible, and really kind of learning from the initial rollouts. We wanted to give that kind of 18-month runway to do all of that learning, to engage with stakeholders, and to really design the framework for what enhanced care management will be for children in youth. So there's going to be a lots of opportunity for additional input.
Excellent. All right, two more. Is there any impact on healthcare programs for children in foster care? PHN program who support children in child welfare.
So I think that's another open question that we'll continue to look at through this stakeholder process. We are also kind of separately from the Enhanced Care Management Initiative, also working with stakeholders in a foster care model of care work group. And so thinking about options for foster youth and what really is the right service delivery model. And there's a few things that are kind of in the works related to the foster care population. And we've been engaging stakeholders on that front for some time. And so I believe that, there will be kind of some really very focused, specific work on the foster care population and what that looks like. And it may look a little differently, depending on how we move forward, but definitely that's a population of focus that is, kind of on the radar of the department, and we're actively working to identify the best pathways forward for children in foster care.
Awesome. Okay, last one. Feels like there is a continuing push to get all Medi-Cal qualifying kiddos into managed care. We try hard to stay with straight Medi-Cal fee-for-service for really strong reasons. Will this option continue, or will we be pushed more and more to not be able to do that?
So there are some requirements through the CalAIM initiative around mandatory enrollment for certain populations, like dual eligible individuals, for example, and that include children who are dually eligible. There will be some children in fee-for-service, but in large part, most of the children statewide are expected to be in the managed care delivery system. At least, but that doesn't mean that there aren't still some options for fee-for-service. But this really isn't my area of expertise, also, so I don't want to say something wrong on that front.
Yeah. Well, I think we could just add that with the whole child model, right, that's going to be evaluation coming at the end of 2022, early 2023, and no decisions will be made about what to do about expanding the whole child model, which would be moving kids out of fee-for-service CCS into managed care until after that. So there's lots of time for a discussion about that and how that moves forward, if at all.
Yeah,
and I will just,
I think.
Yeah, I was just going to add from, again, not sort of the nitty gritty policy technical expert by any means, but just I think globally, not necessarily for CCS or complex kids, but globally, the entire nation has been moving towards managed care, and we have too. I think from the quality perspective, the benefits of that are that you can really build in the wraparound services, care coordination, case management in a much more robust way. I think in, older eras, historically, if there wasn't a managed care entity to do that, that burden was left to the providers, some of which had varying capacities to do that. And our fee-for-service reimbursement doesn't always allow for that, or states had to try to build out that infrastructure themselves, which, for a state as large as California and as diverse as California, I think is really hard to do at the state level. So I think, tied to population health management and quality, the managed care shift makes a lot of sense. But obviously for really complex populations, and CCS has many of those care management functions built into the program, waiting for the evaluation and understanding that specific population more definitely is what's going to happen next.
Great. Well, thank you both. And I'm about to turn it back to you to talk about our third and final set of topics and other important program updates. But I think Medi-Cal RX, which is a transition rolling out January 1, is going to be one of the key programs in this section. So take it away.
Okay. So we are going to be providing some updates on Medi-Cal RX as well as some of our HCBS programs. Medi-Cal RX, as you know, is launching in January of 2022. The intent of the Medi-Cal RX is to standardize the Medi-Cal pharmacy benefit statewide for shifting from a managed care to fee-for-service, which is a critical step as part of our CalAIM initiative. It will standardize the benefit under one statewide delivery system. That means that no matter where a person lives, they would have the same access to prescriptions across the state. So again, some of that standardization that Paul was talking about earlier. It improves access to pharmacy services, and we've already enrolled, I think, 93% of the pharmacies statewide that are eligible to enroll and already providing services. It'll centralize pharmacy policy and strengthen California's ability to negotiate state supplemental drug rebates with drug manufacturers. DHCS will maintain control of the Medi-Cal pharmacy policy, and so that is not being kind of delegated to our Medi-Cal RX vendor, Magellan, including the pharmacy policy, including drug coverage, rebates, and prior authorization management, as well as establishing the network, is all going to continue to be the responsibility of DHCS. It will not change the scope of the current pharmacy benefits or the provision of pharmacy services in an inpatient or long-term care setting, regardless of the delivery system. The existing managed care pharmacy carve-outs for blood factor, HIV, AIDS drugs, antipsychotics, and drugs used to treat substance use disorder services will continue, as well as state fair hearing processes will not change, and any pharmacy services billed as a medical or institutional claim instead of a pharmacy claim. None of those things will change. We do know that this is of great concern to all of you, and when we are really looking to make sure that there is a smooth transition to Medi-Cal RX, and have taken additional time to launch the initiative and working with our vendors. Really, we want to ensure you that Medi-Cal beneficiaries are front and center with Medi-Cal RX, our #1 priority. And beneficiaries will have a 180-day transition period to Medi-Cal RX to ensure that there is no disruption in access to medically necessary prescriptions. We will also kind of use a grandfathering in prior authorizations to make sure, again, that there is no disruption, and that services that were prescriptions that were previously authorized by the Medi-Cal managed care plans would continue to be authorized. Managed care plans will have clinical liaisons employed by Magellan who will be able to directly assess beneficiaries who are enrolled in a Medi-Cal managed care plan with any pharmacy-related matter, including any urgent or time-sensitive requests, any updates on prior authorization statuses, or any claim issues. So there will be somebody within Magellan who is assigned to each plan who will kind of provide that role and make sure, and it's not just one person, but there will be liaisons to each plan who will make sure that your individual questions are answered if you are a managed care member. The Medi-Cal RX program provides counties, managed care plans, and county California Children's Services and California Behavioral Health Programs with access to statewide beneficiary pharmacy medication history to better manage the transitions of care for managed care members, as well as for those in CCS and behavioral health plans. And you can all use the Medi-Cal RX pharmacy locator tool on the Medi-Cal RX portal to find a convenient and enrolled Medi-Cal pharmacy. And like I said before, we've enrolled 93% of the eligible outpatient pharmacies throughout California. We are currently working on several kind of outreach activities to get ready for the transition, including sending out beneficiary notices, which I believe the first round of notices have already gone out. We're doing pharmacy and prescriber outreach and education, and working with our partners to make sure that they are ready for this transition. We're doing that directly with the managed care plans and 19 professional association partners. We're engaging partner outreach channels to reach prescribers and pharmacies through webinars, phone calls, newsletters, YouTube. There's guides available on the website. And we started that outreach and education effort well in advance of the transition to make sure that folks are aware of kind of what's happening. We do have a lot of information about the transition on our DHCS Medi-Cal RX transition webpage. The website includes information including the frequently asked questions, information about complaints and grievances, the website and pharmacy portal policy, as well as the clinical liaison policy, which are the kind of Magellan liaisons that we just talked about. Oops, sorry. And you can sign up on the website for our Medi-Cal RX subscription service so that you are notified by email if there are new items posted or new information available about the Medi-Cal RX program. You can also email the department if you have questions, comments, or concerns at rxcarveout@dhcs.ca.gov. And with that, I think we'll turn it back over to Mira.
All right. So Allison, thoughts about Medi-Cal RX transition? Any concerns, things you're watching?
So my thoughts have been, it's been a really beautifully built out program. It's very thoughtful. I know that they wanted to have it go out January of 2021. The pandemic happened and they purposely put it on hold to make sure that everything was going to be right when they did it. And so I think that that was really great because they could have rushed it out. They did not. They just chose to hold it. They continue to have more and more pharmacies enrolled into it. And so I think any level of care, like it's not for lack of planning. Like they've done a really good job from what I see. The one thing as like a parent is there's going to be hiccups, but they also covered that with the 180-day grandfathered in period. So I think that would be my only thing is when it kicked in, you know, there would be some things that would go wonky, and it seems like they're covering that. And so maybe after the 180-day period, like if they didn't catch it all, there'll be something that's a concern. But I think like for kiddos that have compounded medications via G-tube, like those end up like, it makes life complicated. You really get kind of caught with a certain pharmacy or how to do it a certain way. And sometimes compound medications aren't done after 5 p.m. And so you're stuck in the hospital waiting until that's done. Maybe that frees it up. Maybe, you know, if the doctor doesn't write for an order early enough and in the day, we would still be able to go home that day because they'd find another pharmacy somewhere that was compounding it and we could get it. So I think that there's some really cool things. And I think that they did a really great job. And the 180-day period, like, was really smart because there are going to be hiccups and it looks like they're covering the bases there. So I'm really excited for it. And I can't say enough good things really from it, all I've heard.
Yeah. And I will say, I mean, one of our member hospitals had spent quite a bit of the time working with the department to make sure that the CCS formulary and things that were really frequently needed for the CCS population were included. So I know they've just been very interested in making sure they serve all the populations and prepare adequately to have the drugs that they need on the formulary. So I would agree with you, and very well thought out. Mike, what are your thoughts from Children Now's perspective?
Yeah, so I appreciate the planning that's gone into Medi-Cal RX shift. I think, you know, there probably will be hiccups. And so making sure that there are some really strong consumer protection pathways is really important for us. I think it also comes down to accountability. I mean, Magellan is another vendor and contractor that the state has. And so making sure that they're holding up their end of the bargain is really important. And then I'd like to throw out a different issue because it's a prescription issue, even though it's not a pharmacy issue, and that is eyeglasses. We keep hearing that a lot of kids in Medi-Cal have to wait literally months to get their glasses. And so it's obviously a prescription that's important for a kid's development, but is not something you go to the pharmacy to get. So there's a sort of a different delivery system for eyeglasses, but we're increasingly hearing that that's an issue. And, you know, expecting kids to wait 3 months when we know that they need vision correction doesn't really make a lot of sense. So I'm hoping that that's an area we can also address in the future.
Great point, Mike, to raise. Okay, we have a lot of questions in here. I think just clarifications about the program and a shout out that Medi-Cal RX sounds amazing. How many times have our families been stuck looking for a compounding pharmacy within transportation reach? Thank you for statewiding this service. But then kind of a follow-up question from the same person. Is there a place to learn what the eligibility criteria are for pharmacies? Can you share how many eligible outpatient pharmacies there are? So I think trying to get at how big is the network that we have access to in the statewiding.
Just to be transparent, we're presenting out today on behalf of the Medi-Cal RX pharmacy team. And so some of these questions are very technical and we'll need to take them back. But we can, I know that there's going to be an option to provide some written responses to folks following the conference. And so we'll be happy to follow up with our team and prepare written responses to some of the questions that we can't answer. I do believe that some of the criteria are listed on our website for Medi-Cal RX, but we can definitely take that question back to the team to provide kind of a more complete response.
And that may actually be true for most of these questions. You know, we have a question here about what happens for Kaiser beneficiaries, over-the-counter medicine. Yeah, so I think these are probably all things we want to direct to the Medi-Cal team. And so with that, I think we have two more small topics for you guys to go through: the HCBS spending plan and money following the person. So maybe we'll jump to that.
Sounds good. Okay. Yeah, so we did want to share some information about two other initiatives that are important and related to children use statewide. So the California submitted a home and community-based services spending plan to the Centers for Medicare and Medicaid Services to access additional funding that was made available through the Americans Rescue Plan Act. As a result of that additional funding that was made available to states, California is making a substantial investment in kind of our home and community-based services infrastructure of about $3 billion in enhanced federal funding to really improve the delivery system infrastructure for California's most vulnerable population. The spending plan includes multiple initiatives across several departments, including the Department of Healthcare Services, Social Services, Department of Developmental Services, Department of Rehabilitation, our Healthcare Access and Information, formerly the OSHPD department, as well as Department of Aging and other partners. We are, so there are multiple initiatives focused on workforce development, so strengthening the HCBS workforce, making sure that there are pathways, for example, for people who are direct care workers, so people like Alison, who are care workers in the in-home supportive services program, are going to be able to access kind of training opportunities, as well as kind of other tools that will help to create kind of career pathways if Allison and others are interested in such pathways for obtaining kind of more permanent employment in the workforce. There's also several projects related to HCBS navigation and transitions of care. So making sure that we're strengthening kind of the service delivery infrastructure, how folks manage and navigate through the system, as well as strengthening and enhancing the home and community-based services capacity and models of care. So an example of that is for our assisted living waiver, we are opening up so that there are no, we're opening up more spots to clear the wait list to make sure that people are able to kind of successfully transition from that program. There's also some infrastructure and support services, so some system infrastructure that will be built in to kind of improve kind of the interoperability and portability of our systems, as well as to make sure that we're collecting kind of the right healthcare data for the workforce for the populations, and able to kind of pull that into some of the work that we're doing elsewhere. That spending plan received partial approval from the Centers for Medicare and Medicaid Services in September, and we're waiting for kind of the full approval from CMS in order to move forward with some of the projects. But many of the projects are going to be launching in starting in 2022, and we do need to expend the funds that are available by March of 2024. And so there will be kind of some really big one-time and ongoing investments in the home and community-based services and delivery system that will really help to kind of improve the infrastructure and availability of services under those delivery systems. We also received a one-time supplemental funding award from the Centers for Medicare and Medicaid Services under the Money Follows the Person demonstration grant. The $5 million one-time supplemental funding award will be used to conduct an analysis, kind of a gap analysis of our home and community-based services infrastructure to see, and one of the things that we would look at is, for children and youth who receive their services through the home and community-based services waivers, for example, what services and supports are available, where do we need to strengthen that infrastructure statewide? What are the gaps in the service delivery system that exists today? So that's one of the things that we'll be contracting with a vendor to kind of do that analysis on behalf of the department. That vendor will also be contracted to help map out our transition to manage long-term services and support. Kind of what happens post-Cal AIM. So we know what's going to happen in the next 5 years, and there's a lot of things that are kind of on the horizon, and some of those things that we talked about today. But really, like, what is the appropriate pathway for increased coordination and supports for paid and unpaid caregivers in the home community-based service delivery system? What is the right pathway forward in terms of our managed care, long-term services and support infrastructure? What are the gaps, and where do we need to fill those gaps? What are the right strategies for moving us forward into the future? So that's what those two initiatives are all about. There's the link on the homepage of the DHCS website to our current spending plan, which I said is still pending final approval from CMS, but that really goes into a lot of depth and detail about all of the various initiatives that are going to be implemented across the various departments in California. So lots of information there and lots of work that will complement all of the work that we're doing with Cal AIM and other initiatives. That's it. I think, Mary, you're on mute if you're talking.
No, thank you. Can you hear me now? I can't see my mute button because this chat box is in the way. So that's what I did wrong. All right. So on the topic of home and community-based waivers, currently there are two websites, one with DHCS and one with Department of Developmental Services. It would be really helpful to have one statewide HCBS waiver site that includes information on DHCS waivers and information on DDS waivers. Also, currently, they're heavily directed towards potential providers and not users. So some feedback on what would be helpful for families. Also, some more feedback. Department of Education needs to create this pathway for workforce in schools. Perhaps they are and I'm behind. And then actual questions. Are there family advisory groups connected with the home and community-based waiver spending?
I think each department is engaging family members in different ways as the projects are kind of developed. Many of the departments are still kind of in the planning phase and won't launch, like I said, until 2022. And so there are opportunities to provide feedback, but each department is kind of spearheading their own stakeholder initiatives depending on the project that they are responsible for administering. And so that's definitely, if you're interested in a particular project, though, you can reach out to the Department of Healthcare Services and we can connect you with the right teams at the various departments who are responsible for the various programs. And we have heard from many stakeholders so far. So we really just try to help facilitate connections to those departments and projects. So if you have feedback, we all would love to hear it. And you can reach out to either to me or to our home and community-based services team at DHCS.
Okay. I'm not exactly sure where these questions fit in, but I want to pose them. For prescribed equipment like a hospital bed, feeding pump, reclining wheelchair, vibrating vest, how does Medi-Cal ensure that they're not paying for equipment permanently for a recipient to a vendor when their vendor requests the equipment back later stating it was a rental?
Sorry, I was looking for the question so I could actually read it for
Sorry,
myself.
we're
But
in the Q&A.
that might be another one that we need to take back.
I need to take back.
Um,
Okay. Yeah, and probably the follow-up question as well. So I will leave that one. And then I just have one more comment. Please include in the contract for the organization that is engaged in the money follows the person resources and requirement to engage families to give feedback. The feedback needs to be statewide to avoid inequity.
Great. Yes, we're definitely planning on including a stakeholder process as part of that contract. So thank you for that feedback, and we'll make sure that the contract reflects that. Thank you.
All right, I'd like to give Allison just an opportunity to comment on either of these topics, or just sign up some closing remarks on all the work the department is doing on these important initiatives.
Sure. So for the home and community-based waivers, that's literally why I came to MCHAP, was because there is a group of kids who aren't like seen or covered. And it's, if you have an intellectual disability, you can get a waiver. But if you are a child who has complex medical needs and you live in the home and you require nursing care, and that care could be done by the parent, then those people aren't covered. Those kids aren't covered in any HCBS waivers. And any of the programs where they talk about the spending, I just think about other kids and their families who are kind of just taken out of the equation, because I know that they had a great push for kids with intellectual disabilities. That's why we have the waivers for those kids, because it took a mom, to go to Reagan to make sure that kids with intellectual disabilities are covered. And so I want to be the mom that makes sure that kids with medical complexities get covered if the parent wants to be the in-home provider. Because I know for investing in IHSS providers, it's really great. There's a path and people can grow. And I'm only interested in being my son's provider and just being there to make sure that he's taken care of in every facet. So there's no other growth that I want. I just want him covered. And so I just want to make sure that those kids and those parents are covered.
Oh, muted again. Thank you for that, Allison. Mike, you got 1 minute. Any closing comments?
Nothing from me.
Oh, you're good.
Hard to follow Allison. Thanks for letting me be here.
Awesome. Well, I just want to thank all of our panelists. I want to thank the department. You have been incredibly gracious to lend us your time. I know you've sent many folks to this conference over the last 2 days, and we appreciate always your receptiveness to feedback and your willingness to talk with us as you work through these really important initiatives, and just all of the hard work that you're putting in on behalf of all Medi-Cal beneficiaries, but also really appreciate that you keep making children with special healthcare needs priority. So we appreciate your time and all your work in this area. And thank you to our advocates, parent advocates and professional advocates for all of the work you do to make sure that the needs of this population are properly addressed and that kids are not lost in the big picture when there's so much to focus on in order to get it right. So thank you everyone for your time today. I think we're turning you loose for a 15-minute break before our next session. So thank you all. And if you did not get your questions answered, we'll be sure to answer them in Whova after the session. Thank you.